Hi everyone, my name is Onowari Victor. I am a neurology applicant and I will be doing the Ching Cheng's comprehensive review in clinical neurology. We are still in chapter 1, cranial nerves and neuro-ophthalmology. So let's begin. Question number 4 says a 58-year-old male presents with a left-sided headache and neck pain that occurred during weightlifting. So left-sided headache and neck pain that occurred during weightlifting. He was concerned because he felt like his left eye was droopy, so droopy eye. On examination, you confirm that he has a slight ptosis of the left eye. What is the cause of this finding? So, this is giving a picture of Horner syndrome and what may have caused this. We know that an activity he was lifting weights and then he had the neck pain and the left sided headache, which is classical for a dissection, most likely a carotid artery dissection. Anyways, so the question says, what's the cause of his findings? So first, we have overactivity of the parasympathetics. We have impairment in oculomotor nerve function. We have underactivity of the sympathetics. We have underactivity of the parasympathetic. We have overactivity of the sympathetic. Now, we know that in carotid artery dissection, there is a disruption of the sympathetic fibers that follows the carotid artery. So, if the sympathetic fibers are denervated, what happens is that you just have continuous parasympathetic activity with no sympathetic activity. Yeah, and that usually explains all the symptoms they have. So let's do a little talk about the innervation of the muscles of the eye and just a little touch about that of the face. Now, the eye actually has a muscle around it called the orbicularis oculi, and then this muscle basically helps to open and close the eye and is innervated by the facial nerve. We call it the orbicularis oculi. Now, like I said, it is innervated by the facial nerve and it helps to open and close the eye. The upper eyelid is actually supported by the levator palpebra superioris. Now, that actually helps to elevate the upper eyelid and it is innervated by the oculomotor nerve. So, while we have the orbicularis oculi being innervated by the facial nerve and helps to open and close the upper and the lower eyelids, the levator palpebra superioris actually aids in lifting or opening the upper eyelid and is innervated by a separate nerve, which is the oculomotor nerve. Now, there is another muscle called the Mueller's muscle, and Mueller's muscle is actually located from the underbelly of the levator palpebra superioris. Now, that muscle also aids in lifting the upper eyelid by about 1 to 2 millimeters, and that particular muscle has sympathetic innervation. Now, the sympathetic also innervates the superior and the inferior tarsal muscles, and that actually contributes to opening and closure of the upper upper and the lower eyelid. Basically, it causes the elevation of the upper eyelid and the depression of the lower eyelid. And that's why when you are afraid, when you are scared, your eyes open up. And that's because of the sympathetic innervation of the tarsal muscles, the superior and the inferior tarsal muscles. Now, we all know that the sympathetics also helps in pupillary dilation, and that's why when you are afraid, also your pupils actually blow out. So, if a patient actually has left Horner syndrome, as described in this case, we're talking about reduced sympathetic innervation to the left eye. Then, this patient will actually have the classical symptoms, which includes one, ptosis. So, why would the patient have ptosis? Ptosis basically means there is drooping of the eye, and this is the fact that the superior tarsal muscle and the molar muscles, which are innervated by the sympathetic fibers, are denervated. Also, we have the second symptom, which is meiosis. Remember that the pupils are blown out or they become dilated due to sympathetic innervation. So when you have no sympathetic innervation, you just have predominantly parasympathetic innervation. That will cause your pupils to constrict. That will be called meiosis. We also have anhidrosis, and the anhidrosis is actually due to the fact that anhidrosis basically means there's reduced sweating. So when we have reduced sweating, the sweating fibers actually travels in the external carotid artery, right? So if you actually have a um, a denervation or a dissection rather at the level of the bifurcation, then it's going to affect the fibers that are traveling through the external carotid artery. But if you have the dissection occurring in just the internal carotid artery, then you will not have any form of anhidrosis. Now, next, another symptom they can have is endophthalmos. Now, this is due to the fact that there is decreased palpebral fissure. Also, we have slight elevation of the lower eyelid. And why would there be slight elevation? Remember, we said the sympathetic fibers helps to depress the lower eyelid. So, back to our question. Our question says that we should pick which one of the following which one of the following is the cause of this finding. So we said the answer here is there is underactivity of the sympathetics innervation. That's option C. So the next question is which of the following is not a known association with this disorder? The first is depression of the left lower eyelid. Now remember we just said that the sympathetics helps to depress the lower eyelid. So if there is no innervation of the lower tarsal muscles, then there will be elevation, not depression. So that's options A. Let's see the others. Meiosis. Remember, meiosis is actually a symptom. Depression of the left upper eyelid. Remember that the left upper eyelid is elevated due to sympathetic activities. That means that if there is a disturbance in the sympathetic activity, you actually have depression of the left upper eyelid. So that's correct. Next is left-sided facial anhidrosis. Remember, if it occurs at the bifurcation, then it will affect the fibers going through the external carotid artery. Endophthalmos, remember, endophthalmos actually occur due to decreased palpebral vision. So the answer is options A. Question number 6. During your examination, you attempt to better localize the extent of the lesion. Which of the following findings will suggest that the lesion is proximal to the carotid bifurcation? So we just said that if there is a dissection at the level of the carotid bifurcation, that will actually affect the fibers, the sweat fibers that runs through the external carotid artery. So let's see. The first is depression of the left upper eyelid. The second is left-sided facial anhidrosis. So left facial anhidrosis, let's keep that. The third is meiosis of the left pupil. The fourth is elevation of the left lower eyelid. The fifth is endophthalmos of the left eye. So the answer is obviously left-sided facial anhidrosis because the sweat fibers actually runs through the external carotid artery and we have a dissection at the bifurcation that will affect those fibers. So that's all for this episode. See you next time.